Hindi ko maganda eh. Put a headset is
ज़्यादा से ज़्यादा 1.5 घंटे का या 2 घंटे का वेबिनार होगा. So you stay there, okay? Don't go out. Please, one of you stay there.
Done. YouTube भी चालू कर दिया.
Thank you very much. Hello, Dr. Iti.
Ross, Sajin, how are you?
Hi, I'm fine. I'm fine.
Yeah, I'm very fine. Thank you for inviting me today.
It's my pleasure. Your comments are always very encouraging. So I thought we can have you.
Thank you very much.
Yeah. Thank you. Dr. Hemanta? Dr. Hemanta, you have to unmute yourself. Dr. Hemanta, you are not audible. Dr. Hemanta?
Hello?
Yeah, now you are audible. Can you share your screen and see whether you're able to share the screen?
Yes. Wait for a while.
Yes, please share. Yes, wonderful. So 20 slides, try to finish in maybe maximum 10 minutes, okay? 5 to 10 minutes, so that we can have more time for the discussion. Now you can unshare your screen.
Okay, sir. Okay.
Yes. Dr. E.
Hi. Yes, I'm here.
Hi, how are you?
I'm good.
Nice to see you.
Nice to see you.
So you have to introduce Dr. Hemanta and participate in the discussion, okay?
Yes. I would like to know Dr. Hemanta family name. Tilaka.
Tilaka, yes.
Tilaka.
Yeah, he's there.
Okay, thank you.
Maybe we'll wait for a 5 minute and then we'll start the session. Okay, hello everyone. Just a small request. Lot of people name is appearing only as a doctor, so maybe you can change the name. So yeah, for that you'll have to go in the participant list and just click on the more. There is one option in the blue color called more. You click on that, it will ask you to change your name. So just change your name so that it will be easy for us to call by their name and identify each other.
そう、頭の髪の毛潰れてんじゃん。これ便利だね、その写真。一枚です。その写真。なんでわざわざ全部渡してくれない？
お世話になりましたけど。毎日ぐらいなんだから美味しいです。
ナスの某クラブがクローズになったりする。それ嬉しくて闇で言ってるんですか？
ナスの
Hello, Sashi.
Hi, how are you,
Hi,
Shane?
yeah, it's Chen. It's Zhihua. I'm here.
You can switch on your video so that I can see you.
Oh, okay, yeah. How are you going? Yeah.
Yes.
I'm
Thank
already
you for
here.
joining. Yes,
Yeah, I'm ready. Yeah,
thank you for joining. Very nice background.
Hi, Sashi. I just want to say hi to you.
Hello,
Hi,
Dr.
Prof.
Javed.
How are you doing?
I'm good. Thank you for joining.
Thank you. Thank you for
So, Dr. Pirzad is held up in some work, so maybe you are there, so thank you for joining.
Oh, no problem.
Are you in Japan? Hi, Sashi. Are you in Japan or in India?
No, I'm in India. I would have been in Japan only if I would be playing Olympics. I'm not playing Olympics, so I cannot be in Japan.
Yeah, how's the pandemic? I heard that the pandemic is better than before.
It is better, but they are predicting that we are going to soon have our third wave. So that will be again another problem.
Yeah. Shanghai, we are facing.
How's there in China?
China is okay, always doing well. But there's some cases were found in Nanjing city and there are several cities. We find the people come back from overseas and then they bring the COVID-19 again. Yeah.
I understand.
We can control the situation. Don't worry about it. Yeah.
Okay.
These days in Shanghai, we are facing the typhoon. Typhoon. The storm is coming.
Oh, storm is coming. Okay,
Yeah,
cyclone.
storm is coming. Yeah. So the storm is attacking in Shanghai, and we cannot go outside. We have to be caution on the road.
Okay.
Yeah. Okay.
Just another 1 minute and then we'll start.
Okay. What kind of the sound? Quack, 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 quack. What kind of the sound? You heard it?
Hello, Dr. Liu, you're there.
Yeah, hi, Sachin.
Thank you for coming. I understand you're very busy.
Hi, Liu. Hi.
Hi, Javi.
Seeing you.
So maybe we can start, Dr. Liu. We've already 10 minutes past.
Yeah, sure. Hello, Sachin. Hello.
Yeah, you want me to share the screen for you?
Yes, yes. Please.
Okay, I'll share the screen for you. No problem. Is it visible?
Yes.
Okay, you can go ahead.
Very good. Evening to all. First of all, I would like to thank Dr. Sachin for this arrangement, and thanks for the good support from our president, Professor Yoko Kato. Today, Dr. Sachin have managed to arrange some great speakers, Professor Goto, Professor Ivan, and Professor Lucas. And we also have one young neurosurgeon who's going to present the case report. At the same time, today we also very fortunate to have Ono, who also will demonstrate to us some of the new neurosurgical or anatomical model that can be used for our learning. And without wasting much time, I would like to call upon our Professor Yoko Kato to give her opening remark. Thank you, Professor.
Thank you, Liu. And thank you, Sachin, for a nice organization of this the monthly the meeting. So I'm very happy to see Dr. Liu with a tie. So it looks very nice. Congratulations. So maybe Dr. Liu and Sachin is the hard worker, day and night. Today I'm very, very happy to see so many fantastic speakers. It's outstanding, the world, the class speakers. So now in Japan, we started just Olympic game the 2 days before, even the pandemic state. But we are very cautious to prevent, to not extending of the pandemic anymore, I think. So already some gold medal and some medalist has appeared, I think. Now I saw during the opening ceremony, I saw the 2 Afghanistan athlete has attended, I think. I thank you so much, even a very difficult situation, I think. So I'm so happy to see many faces that was very vivid and very active. So we'd like to start the seminar today, please. I hand over to Liu or Sachin.
Yes, Yes, so Dr. Fawad Pirzad, the president of Neurosurgical Society of Afghanistan, is held up in a surgery. He'll be joining in another half an hour. Just wanted to make an announcement that ACNS has offered a fully funded fellowship for 4 candidates from Afghanistan. The 2 young neurosurgeon, 1 neuro nurse, and 1 neuro anesthetist. So they will be soon joining in one of the tertiary care center hospital in India, in southern part of the India, and we'll have 1 short-term fellowship. So we are trying to just, learn and see how can we do more education even in this COVID pandemic. So that is what the announcement I wanted to make. So next speaker, I would request Dr. Iti to please introduce the next speaker, please.
Yes, good evening, everyone. I am Itichai from Thailand. For the first speaker, I would like to introduce Professor Takeo Goto. Professor Takeo Goto, he is a very famous scar-based neurosurgeon. He is a very well-known scar-based neurosurgeon, especially in my country, in Thailand, because he visited in my country in many times and demonstrate about the surgery, like a live surgery. And today he will talking about the endoscopic surgery for scar-based tumor. Please, Professor Goto, please give us about your informative lecture, please. Thank you.
Thank you, Dr. Ijay. Today, I feel very honored to have opportunity to present my work in front of the young neurosurgeon of ACNS. So now I will share my slide. Can you see my slide?
Yes, Professor.
Yes, we can see. Thank you.
So now I will start my lecture. A topic today's presentation is brain tumor resection by endoscopic skull-base surgery. Recently, in endoscopic skull-base surgery, endoscope can offer the panoramic wide and clear view, and it largely contributes to less invasive tumor resection. So today I will talk 2 topics. One is endoscopic endonasal approach, and the other is endoscopic keyhole transcranial approach. At first, I will talk about the endoscopic endonasal approach. Even transcranial approach, resection of the tumor around the central skull base very difficult, but this is a simple illustration around the central skull base. If we access this region through the nasal cavity, the only obstacle to access this central skull base is just bony structure, such as clivus, pterygoid process, petrous bone, and the posterior crinoid process. If you have the mastered surgical technique to drill out the all bony structure, such as pterygoid process, petrous bone, and clivus, you can directly access the central skull base without crossing over the vascular structure or cranial nerves. So I will show the several cases of the endoscopic skull base approach. This patient is craniopharyngioma, and the posterior part of the tumor protruded to the posterior fossa. But if we observe the craniopharyngioma by the endoscopic endonasal approach, the tumor looks like this. Bilateral posterior clinoid process is just obstacle to access around the pecon. So if we drill out the posterior clinoid process on both sides, we can widely expose the tumor like this. So I will show the surgical video. At first, I widely drill out the bony structure. And then this is a pituitary gland. And this is a posterior clinoid process. I gently drill out the posterior clinoid and carefully remove out. This is a medial wall of cavernous sinus. And this is a pituitary gland. I mobilize the pituitary gland and cut the dura mater behind the dorsum sella. After drilling out the posterior clinoid, we can reach around the oculomotor nerve. This is a border between pituitary stalk and the tumor. And this is a PCA, pecon, and this is a optic tract. And this is a optic pituitary stalk. Using this approach, we can directly dissect the tumor from the critical structure. And then, finally, all tumor was successfully resected out. Post-op, all tumor was resected out, and also we can preserve the posterior pituitary function. Of course, we need the corticosteroid, but other hormonal state was preserved. This is another case of the very large diaphragmacellar meningioma. Attachment of the tumor is a diaphragm and completely compress the hypothalamus like this. If we choose the transcranial approach, it's very difficult to access this region because the tumor located completely within the circle of wells. So I choose the endoscopic endonasal approach because attachment is here. At first, I widely drill out the bony structure around the sella and the skull base, and then cut the dura mater and mobilize the pituitary gland right side. Now I expose the attachment of the diaphragm and coagulate and cut. In case of the meningioma, devascularization and detachment is the most important surgical step. After detached and devascularized, tumor looks bloodless. So we can carefully dissect from the critical structure in the very bloodless surgical field. This is a border between optic chiasma and the tumor. And dissect out. And finally, all tumor was resected out. This is a basilartery and PCA. In case of the meningioma, we have to carefully close the skull base. I usually insert the fat tissue to subdural layer and put some suture to the dura mater. And then we confirmed the skull dural defect was almost watertightly sealed, and then cover the nasal flap. After that, tumor was totally resected out, and his vision dramatically improved, and pituitary function also completely preserved. This is another case of the posterior clinoid meningioma. Attachment of the tumor is a posterior clinoid. If we access through the nasal cavity, posterior clinoid located here. So it's very easy to directly access this area. I will show the surgical video. This is a pituitary gland, and this is a right cavernous sinus, and this is a carotid artery, and this is a posterior crinoid process. I mobilize the pituitary gland upward and expose the posterior crinoid process, and then remove out the posterior crinoid. After remove the posterior crinoid process, we expose attachment of the tumor and then coagulate the attachment. In case of the skull base meningioma, coagulation and cut, the attachment of the tumor is very important. And then I completely detach. This is a carotid artery, and I carefully remove out. This is a pecon, oculomotor nerve, and this is a pituitary stalk, pituitary gland. So the drill out the posterior crinoid was very effective to access this region. Postoperatively, the old tumor was resected out, and her symptom completely improved. This is another case of the recurrent lower cranial meningioma, the region located medial side of the lower cranial nerve. So if we access the transcribal approach, attachment is here. So if we drill out around this area, we can directly access attachment of the tumor. This is a clivus, and this is a paraclival carotid artery. I drill out all bony structure around the lower clivus. After coagulate the dura mater around the clivus, tumor already devascularized. So we can carefully dissect the tumor. This is a vertebral artery, and this is a sixth nerve, and this is a ica, and this is a lower cranial nerve. Using this approach, already tumor was detached and devascularized. This is a tip of the skull-base meningioma surgery. I carefully resected out the rest of the tumor. This is a facial nerve. I dissect from the facial nerve, and finally, all tumor was resected out. Postoperatively, the tumor totally resected out, and her symptom dramatically improved. This is another case of the recurrent petrous chondrosarcoma. At first, I planned to choose a transcranial middle host approach, but through the transcranial approach, it's very difficult to drill out this bony structure. So I choose the endoscopic endonasal approach. At first, I widely expose the pterygoid process and coagulate the Vidian canal and drill out the clivus and the petrous bone. This is a petrous carotid artery. Bone work was very important. This is an exposed carotid artery. I mobilize the carotid artery to lateral side and drill out the bony structure around the jugular tubercle. And then this is a tumor around the petrous bone. I mobilize the carotid artery to lateral side and remove the tumor. Now I expose the 7th and 8th nerve like this. And this is a tumor lateral side of the carotid artery. I confirmed that all tumor was resected out. Postoperatively, this is a carotid artery, so all tumor was successfully resected out, completely epidural procedure. This is a very safe procedure. Now I will talk about the endoscopic keyhole transcranial approach. At first, I will show the anatomy of the endoscopic keyhole subfrontal approach, then show the keyhole subtemporal approach. When performed the endoscopic keyhole subfrontal approach, I put the skin incision around the eyebrow and make the craniotomy about 3 centimeters, and then directly insert the endoscope to frontal base. Using this, we can expose the olfactory nerve, proximal sylvian fissure, frontal lobe, frontal base at the same surgical field. It's very beneficial to remove the frontal base tumor. Through this field, we can open the proximal sylvian fissure or identify the third nerve. And if we move the endoscope more medial side, we can expose the optic chiasma, tuberculum sera, and frontal base. And then we can drill out the bony structure around the optic canal and tuberculum sera. After the cadaver study, I use this approach to tuberculum sera meningioma. The size of keyhole is about 3 centimeters. And then I insert the endoscope to frontal base. This is a tumor around the frontal base. And this is a left optic nerve. Endoscopic surgery is relatively easy to drill out the optic canal or tuberculum sera, even in the small surgical field. I completely open the optic canal on the left side. And this is a tumor medial side of the left optic nerve. In this case, I choose the left frontal craniotomy, but it's easy to medial side of left optic nerve. And then I remove the tumor by QSR. And this is a medial wall of contralateral optic canal. And I remove the tumor around the right optic canal. And finally, we confirmed all tumor was successfully resected out. Postoperatively, all tumor was successfully resected out. I will show another case of the olfactory groove meningioma. In case of the olfactory groove meningioma, this approach also very effective. This case, the size of craniotomy is about 2.5 centimeters, and then insert the endoscope to the frontal base. This is the attachment of the tumor. I carefully coagulate and remove the attachment of the tumor by QSA and scissors. This is a frontal base, and I perform the internal decompression piece by piece. And this is the inferior surface of the frontal base. This panoramic view was very effective to confirm the all tumor margin and resected out all tumor. Craniotomy was very small, but finally all tumor was successfully resected out without any neurological deterioration. And also I could preserve the right olfactory function. This is an anatomy of the endoscopic subtemporal keyhole approach. In case of the subtemporal keyhole approach, I make the skin incision around this area and put the craniotomy about 3 centimeters, like this, and insert the endoscope. After insertion of the endoscope, we can observe the tentorial edge, third nerve, and Meckel cave. If we open the Meckel cave, we can resect out tumor around this. So I apply this procedure to trigeminal schwannoma. At first, I put skin incision and the size of craniotomy about 3 centimeters. And then I carefully mobilize the temporal base and insert the endoscope. This is a dramata over the trigeminal nerve. And I cut the dramata over the V3. I carefully coagulate and cut the dramata. This is a superior petrosal sinus over the Meckel cave. And then I cut the SPS around the Meckel cave. Now Meckel cave completely opened, and we can expose the fifth and fourth nerve. And this is the tumor medial side of the trigeminal nerve. I start the tumor removal. This surgical field is almost same, the transcranial microscopic approach. So we can safely resect out this tumor from the trigeminal nerve or carotid artery. Now we expose posterior fossa. Finally, skin incision small and the tumor was totally resected out. This is a last case. This case is a recurrent chondrosarcoma associated with osteogenesis imperfect. Patient has some problem around bony structure. So the angle is very steep. So transcranial approach seemed to very difficult. So I choose the endoscopic endonasal endoscopic subtemporal approach. Surgical field is the same. At first, I elevate the temporal lobe and expose the tentorial edge. This is the fourth nerve, and this is the trigeminal nerve. I resected out the tumor around the tentorial edge very carefully and dissect the tumor from the brainstem. Endoscope can offer the panoramic view. So the size of craniotomy very small, but we feel the surgical field not small. So we can follow the border between tumor and brainstem, and finally dissected out all tumor. This is a brainstem. I carefully dissected out. And in addition, the three-hand technique also very important for gentle dissection of the tumor. And finally, all tumor was resected out. Tumor was totally resected out, and the patient not show the complications. So today I will explain the two endoscopic surgical approach. One is endoscopic endonasal approach, and the other is endoscopic keyhole transcranial approach. But surgical technique of this approach is almost same. So this approach can be very effective procedure for removing the complicated skull-based tumor. Thank you for attention.
Thank you, Professor Goto, so much. You look like a magician because you can apply endoscopy in everywhere. It for the skull bed, not only endonasal, you can approach to in everywhere. But you can show really fantastic and very perfect and very clear about the operative view. We clearly understand about your philosophy. So can I ask you one question? Do you have tricks and techniques to avoid the injury of the ICA when you face off a very big giant pituitary adenoma and approach via endonasal? Professor?
Yeah, if the size is very large, but the tumor itself localized central skull base, I just choose the endoscopic endonasal approach. But some large pituitary adenoma extend to the lateral side. in such case, I choose the combined approach, transcranial and endoscopic approach, to remove out all tumor. In some cases, if we left behind some tumor, the residual tumor shows bleeding. So if the large pituitary adenoma to extend to the lateral side, I recommend the endoscopic, transcranial, and endonasal approach at the same time. This is my opinion.
Thank you, Professor. Is there any question from the panelists?
Can I? Ichi?
Yes, thank you, Professor. Please.
はい、こんばんは。後藤先生、thank you very much for a nice presentation as always. 先生、I want to ask one question about brainstem capilloma, the bleeding case. So is it possible by endoscopic subtemporal approach? So what is the contraindication for endoscopic procedure? Can you tell us, please?
It's very difficult question. Of course, if the capilloma located the lateral surface of the pons, we can access endoscopic temporal approach. But in case of the capilloma, in some cases, the tumor tightly capilloma itself tightly adhere to the brainstem. In such case, microscopic subtemporal is better than the endoscopic approach. This is my opinion. In case of the vascular region, of course, in most cases, we can resect it out, the endoscope. But in some cases, control of bleeding is very difficult. So the size of the craniotomy not so different, the transcranial and the subtemporal. Keyhole is a 3 centimeter, but microscopic subtemporal need just 4 centimeter or 5 centimeter craniotomy. The difference of the size is just 1.5 centimeter or something. So usually I choose the microscopic procedure in case of the vascular region. It's my opinion.
Just one more question. So do you have some idea in the future of the endoscopic procedure? So it's very limited to use the instruments because it's very tight, the place. Yeah. So do you have any the good idea? But I think endoscope is very good, I think, a feature.
Yes. I think in near future, I think the number of the endoscopic case increase. So we have to develop the monoshaft surgical instrument, more sophisticated monoshaft and surgical instrument required. Bipolar, scissor, all surgical instrument. Monoshaft is better than the microscopic instrument. So we have to develop the. Thank you.
Thank you, Professor. Please, Professor Persas, can you ask Professor Goto for your question, please?
Yes, thank you very much, Professor Goto, and for your nice presentation. I like to ask about what is your advice for macroscopic approach in countries like Afghanistan? There is no microscope and no endoscope.
Okay, I think the concept of the skull-based approach is just access the attachment of the tumor. So if you use a microscope, the selection of the surgical approach is almost same. The direction to access the region is very important. If, for example, the transcribal approach, even the transcribal approach, I think you can perform the microscopic sublabial transcribal approach can be performed. Okay, so the surgical direction not cross over the critical structure like the cranial nerve, vascular structure is the tip of the skull-based tumor removal. So if you cannot use the endoscope, but the concept is almost same. It's my idea or comment.
Thank you.
Thank you, Professor Goto, for your very great lecture. We all thank you everyone. Thank you for your lecture so much.
Thank you.
Thank you.
So, Professor Takeo Goto, I have a question. Now we are now discussing about sort of building a capacity of neurosurgery in these low resources countries like Afghanistan, Myanmar, Sri Lanka, and some countries where the available endoscopes are not very high tech. They have only single channel where only one instrument can be passed. So in such countries, what do you think? How can the endoscopic neurosurgery can be built up? What is your opinion? How can we build up the anatomy knowledge, or how can we bring up the instruments and the scopes here? What do you think?
In my of course, endoscopic surgery is a new surgical technique, but compare the cost, microscope or endoscope, which is expensive. I think the microscope is expensive. So I think in the developing country, I think it's easy to introduce the endoscope compare the microscope. So it's like the smartphone in African country or many country use a smartphone. So I think it's the same situation. So in my idea, near future, many institutes use the endoscope. The instrument is not so important. If we observe the region, you can perform the endoscope in near future. Of course, but we have you have to introduce a high definition endoscope. It's my idea or comment.
Thank you. Thank you very much, Professor. So for the young neurosurgeon, it's always, the understanding of anatomy and more practice is a challenge. So today we have Professor Hidehiko Ono from Japan, and who's been working with this models building, especially for the young neurosurgeon, for two reasons. First of all, to make a sort of some simulation available for the young neurosurgeon to practice one thing, and to make the knowledge of anatomy more clear. So I'm going to introduce you to Professor Ono, who's going to talk to us very briefly for 5 to 10 minutes about these models he has. And these are not very expensive models. So if you are in capacity of approaching to him, please try to get these models from him, and you can practice very well, especially for the young neurosurgeon. Professor Ono, can you please share your screen?
Sure. Thanks very much, Professor Sachin, and thanks very much for Professor Goto Sensei for the wonderful explanation. And as Professor Sachin mentioned, our company do manufacture and sell those surgical simulation models, especially for both training purposes as well as informed consent purposes for the patients. And with probably taking next 5 minutes ish, I'd like to talk about our company, what we do, who we are, and how probably we can contribute to ACNS going forward. With that, I'd like to share my screen. Can you see my screen, please? I take that.
Yes, yes, Professor.
The first Well, I'd like to show our special thanks to Professor Kato, all the members of ACNS, as well as other professors around the world, including Professor Goto Sensei, to give me a wonderful opportunity to present our company, what we do, and what we could probably be able to achieve ACNS members going forward. The content of my presentation is very simple, or the following 3 topics, which may not take more than 5 minutes, and I'd like to leave time for other professors for their presentations. And the first of all, we are manufacturer and medical model and medical device. If you go to our corporate homepage, a corporate website, all the models are available via photo, or as well as some of the models have YouTube video links. And we mainly focus on endoscope and as well as endovascular, but with that, I want to talk about our models later. And our company, probably some of you may have known as owner and the company, and some of you may have met my father, our chairman, Hidenori Ono, of whose picture is shown on the presentation. And with superb help of Professor Kato, or my father has a fortunate to travel around the world to help ACNS, hands-on training, not just or Nagoya area, but also around the world, especially in Asia. And our company was actually established back in 1897, but we separated medical business in 2018, 3 years ago, to focus fully on medical. And my father watches both, our traditional business as well as medical business, and I mainly focus on medical business. And what we do medical model manufacturing and selling. Our brand name is called Kesrex. And I'm going to talk this a little bit about later. And another business is we do also manufacture of remodeling helmets for infants. This is more for after the surgery of craniostosis, as well as plagiocephaly. And the Kesrex model is mainly for neurosurgeons. The goal of our model is for, or as Professor Sachi mentions, for education, mainly for hands-on training, as well as surgical simulations. And some professors in Japan use our models for informed consent. If you go to Google and search the word Kesrex, you may see our product line as well as how to use in corporate website. And should you have time, we are more than happy to go over one by one. And please contact me via corporate website, inquiry page. And another business which we do is remodeling helmets for infants. Some of probably your countries may have, or US-made products, and our product is only made in Japan. And in Japan, more than 4,000 patients have been using a remodeling helmet to reshape their skull, either or both plagiocephaly as well as craniosynostosis. And we desperately looking for both Kesrex and IMET Asian partners, especially neurosurgeons who want to try our model as well as remodeling helmets therapy for the infants. What we would like to achieve, our company is the bottom line. We want to make doctors and patients happy. And we want to contribute to neurosurgeons around the world, especially ACNS. After hopefully probably COVID-19 situation to get ease year or two, we would love to travel around in Asian countries to for the opportunity to use our models for their training, mainly endoscope probably for next 2 years-ish. And our company, for those methods, we want to change the world to be a better place. Although I'm not a doctor, nor any of our employees, not medical doctors, we would love to work with all the doctors, ACNS, and the others to help them as well as help patients to live in a better place. With that, thank you, and please search in Google the word KEZLEX or go to this QR code, which directly goes to our corporate website. Thank you.
Thank you very much, Professor Onno. So actually, if you can go to their website, KEZLEX, you just have to type KEZLEX and Google will take you there. They really have some wonderful models, vascular models and endoscopic models. So you can actually, yeah, that's the website. If you open this, so that's a beautiful vascular model. So you can actually, they've given the clips also along with that. You can put the clips. You can drill your temporal bone and drill out the jugular sinus and the transverse sinus. And even for endoscopy, you can actually put your endoscope both transcranial and endonasal. Endonasal you can practice for your pituitary surgeries, and transcranial you can actually practice, evacuation of hematoma. You can just put a jelly there and you can remove the hematoma. So that's the pituitary surgery. So certain wonderful models. So I would say it is like, you can do stepwise. First you can practice on these models, and then you can go to your cadaver lab, and then with some senior faculty in the OT, you can have a little hand of holding the instruments, and that's how you can take ahead the endoscopic surgery. Because there is a very steep learning curve, especially in the endoscopic surgery, and any small mistake can be disastrous. So thank you very much, Professor Onno.
Thank you.
Can you just tell a rough cost of this endonasal pituitary removal, the cost of that model?
That'll be, excellent questions. We are trying to reduce our cost of the products for last few years, and probably going forward, we may do subscription business model, which means that probably we're gonna rent entire outside of the model, and inside, which is disposable part. Probably you may be able to use 10 or 50 disposable parts per year freely, and on those subscription model, as well as moduling with any anatomy requests. Probably we hope to get things done $1,000 US per year. Which I need to get approval within the corporations, but we hope to provide those subscription business model for each cost maybe $1,000 US per year. I hope that will be affordable for each university or doctors going forward.
Thank you very much, Professor. But it's a very diplomatic sentence. Maybe for certain developed countries or developing countries that may be affordable, but for some low resource country, maybe you can come up with some discount. So thank you very much. Any other
cost reduction will be required, and with special advice by Professor Kato, as well as other professors such as Professor Muto, we are thinking, and hopefully within weeks-ish to get a special cost for developing countries and a subscription model, so that each young neurosurgeons can use our models a couple of times per year with certain limited cost.
Sure. Thank you.
小野さん、ありがとうございます。
ありがとうございます。
素晴らしい。Excellent lectures. Thank you very much.
Thank you. Is there any other question? If no question, then we'll go to the next speaker.
Sachin, one question to Dr. Goto.
Yes. Dr. Rajesh, are you there? Dr. Rajesh, you wanted to ask a question? Shall I ask for you, or you want to ask yourself? maybe I'll ask for him. So Professor Goto, Dr. Rajesh from India, he has a question for you. He's asking, which surgery should be done first when doing both transcranial and endonasal for giant adenoma? Whether to go endoscopic transnasal first or to do transcranial first?
Okay, I already answered the email to him, but
Okay.
In case of the giant pituitary adenoma, I not recommend the staged surgery. So you should perform the transcranial and endoscope at the same time. If we plan the staged surgery, residual tumor may cause bleeding. So I think this stage surgery will be very risky procedure in case of giant adenoma. So if necessary, we plan the both approach at the same time. Okay.
Thank you very much, Professor. It's actually very wonderful to see both the approach at the same time. We have a different endonasal surgeon, a different team, and transcranial different team. And inside the brain, both the teams are meeting together. So it's a very beautiful and weird movement. Thank you very much. Any other question from the participants or delegates? If no question, then we'll go ahead with our next speaker, and then maybe after him we can come back to the question and answer session. So let me take an opportunity to introduce the next speaker. Next speaker is Professor Lukas Rasulik from Serbia. Is my screen visible to you? Hello?
Yes, Sachin.
Okay, so he's currently a neurosurgeon and professor at the Faculty of Medicine at University of Belgrade, and he's head of the Department of Peripheral Nerve Surgery, Functional Neurosurgery, and Pain Management Surgery at the Clinic of Neurosurgery, Clinical Center of Serbia. And his main clinical and scientific area of interest is peripheral nerve surgery. The whole world knows him for the peripheral nerve surgery. He's in charge for the WFS Committee for the Peripheral Nerve Surgery and Blackest Plexus Surgery. Apart from that, he's the president of Serbian Neurosurgical Society, president of Southeast Europe Neurosurgical Society, and ACNS 2022 Congress, which is going to be in the next year. He's also a chair of EANS, that is European Academy of Neurological Surgeons, section of Peripheral Nerve Surgery. Member of a lot of neurosurgical society. He has more than 450 scientific publications in the international and national scientific papers in index journals and chapters in scientific books. He was faculty at more than 100 international courses and trainings, invited speaker at more than 100 national and international congress symposia, organizer of more than organizer of more than 60 national and international congress meetings and symposia, and active participant at more than 180 international and national scientific meetings and scientific participation. So with that introduction, I invite Professor Lukas Rasulik. Please kindly share your screen and
Good afternoon, everybody. I hope you can hear me. I hear some sound deviation. I don't know why.
I'm just trying to help you with that.
There is maybe some other
Yes.
device.
I think that should be okay.
Yeah. Thank you very much, dear Sachin. Thank you very much for this kind introduction. And I would like to extend my personal gratitude for all support of Professor Yoko Kato and kind invitation for this and giving me opportunity to give a presentation on this outstanding educational activity which Asian Congress of Neurological Surgeons is constantly performing, especially on the occasion of Afghanistan, Myanmar support and education of young neurosurgeons. And as it was said in introduction, my field of expertise is peripheral nerve surgery. So I don't have anything to disclose. I just want to remind you several facts that are very important, that peripheral nerve surgery is an essential part of neurosurgery, and the neurosurgery is surgical discipline by definition, which is treated surgically treated nerve disorders, and the nervous system is consisting of central and peripheral. So despite that not many neurosurgeons so far are involved in peripheral nerve surgery, now we can say that there is a significant raise of interest for peripheral nerve surgery within young neurosurgeons, and I hope that it will continue to improve. This is a pathology which is we don't have any big incidence, but incidence is not so small. It's highly influential and have a great impact on quality of life, affecting young people. And this is, generally speaking, reconstructive neurosurgery. Impact is very well defined also in terms of all aspects of quality of life, not only motor function. And this is a famous photo from National Geographic, which represent waiting for the patient recovery after surgery. Zbigniew Religa wait 23 hours after heart transplantation, but we are waiting for a little bit longer time for reinnervation and regeneration of the nerves. And this waiting is, let's say, approximately around 1 year. And this is maybe the reason why neurosurgeons are not very interested in and involved in this surgery, since you don't have any evident results of your surgery at the moment when you finish the surgery. Another very important issue in this field is that when you make a choice of surgical treatment strategy and in the decision-making process, you still are, let's say, pending between coin flip-based decision-making as a matter of interoperative finding and surgical experience, and the lack of class 1 evidence based on preoperative evaluation. So that's why we have criteria for class 1 evidence base are very clear, and we have to work on this to, let's say, introduce more international multicentric double-blind randomized cohort studies because of their outstanding importance in terms of decision-making process according to the class 1 evidence based in this pathology. But question is, the peripheral nerve surgery as important as clipping an aneurysm or resecting a brain tumor or spine stability is not very actual anymore, because the answer is simple, it is. And it is a essential part of neurosurgery, as I mentioned. So now, nowadays in 21st century, in terms of crisis versus opportunity or challenge versus opportunity, peripheral neurosurgery offers opportunity for change and evolution, research and innovation, high impact on quality of life of the patient, and leading to the patient satisfaction. We have also biological challenge versus opportunity. Nerves are regenerating, repair is possible. Why our results are not better? we do know that regeneration is slow, suffered, and hazard. All nerve injuries are chronic, and reinnervation is misdirected, non-specific and imprecise, and this is the reason why results are not better. Another big issue is complexity of anatomy, surgical anatomy of the nervous system, especially as it's used. You can see here in this example, anatomy of the cervical and brachial plexus. And you have to know not only topographic anatomy, but you have also to know intraneural systematization of the nerve elements. Still, there are several controversies in surgery on peripheral nerve injuries, but especially in terms of making a possibility for doing this surgery in low and middle income countries, and generally speaking, actually current standing in this surgery can be named as KISS, keep it simple surgeon. This is standard procedures in 21st century for doing peripheral nerve surgery all over the world, no matter whether the conditions and technology are available, better or not good enough. Generally speaking, we have very clear indications for surgery in open injuries, closed injuries, and in acute exploration, possible repair. We have to recognize these situations and to make an indication, to make an exploration, and then to make a primary suture in sharp, clean cross-section of the nerve if there is no nerve defect, or delayed primary suture, or early secondary suture, or delayed secondary suture, depend on the timing in open or primary repair. In the closed injuries, timing of nerve repair is, let's say, defined through monthly evaluation, and this is due to the fact that in closed injuries there might be possibility for spontaneous recovery of the nerve elements due to the second and 3A grade of Sunderland lesions. But generally speaking, when we are talking of the nerve lesions, we are talking about three pathological entities. One is nerve lesion in continuity, another is nerve lesion without continuity, and third one is lesion with and without continuity, which means mixed combination of the lesion of the one nerve element. So when we have a nerve lesion in continuity, we have simple procedures such as exploration, nerve dissection, external neurolysis, and this is an example of external neurolysis of the left peroneal nerve, and this is how it looks like when the initial signs of recovery are present. Practically very soon after surgery, timing in this situation is very important. When we are talking about internal neurolysis, this is another issue, and these are some schematic drawings of internal neurolysis, and this is, for example, excellent example of excellent useful functional recovery of the median nerve following internal neurolysis of right median nerve after injury. But if we have a question external or internal neurolysis, external neurolysis is mandatory, and internal neurolysis should be adjusted to the grade of the intraneural scarring and should not result with isolated fascicles. So neurolysis is one of the standard procedures in peripheral nerve surgery. Direct suture is another procedure, and this is ideal method in acute phase, and later phase using nerve gap reduction procedures also can offer possibility for the direct suture, but this gap must not be longer than 1 or 1.5 centimeters. So when we have a nerve lesion without clear transection, we have to make a stump preparation, approximation, cooptation, and maintaining the cooptation procedures. These are stump cooptation techniques: epineural repair, stump to stump, or fascicular group to fascicular group, so-called group fascicular repair, or fascicle to fascicle, such as fascicular reparation. Maintaining of stop coaptation can be performed using microsurgical suture, 10-0 suturing, usually most likely epineural. And then maintaining of stop coaptation can be done also with no suture techniques using fibrin glue most frequently. There are some factors that affect the gap distance and which can, let's say, influence to the stump approximation, such as defect of nerve tissue due to the injury, defect of the nerve tissue due to the stump preparation, elastic retraction of the stumps, fibrous retraction of the stumps, and joint position. There are such additional procedures for reducing gap distance between nerve stumps, such as mobilization, transposition, and joint position. And these are some examples of direct suturing. When we have a nerve gap longer than 2 centimeters, we perform nerve grafting. We never perform nerve grafting primarily. There are some disadvantages, such as 2 suture lines, difficult identification of a property fascicle, and fibrosis of a distal suture line or long graft. The results of direct suture are always better, even in relation to those using short grafts, but still, nerve grafting has excellent result in approximately 80% of cases. Non-vascularized and vascularized nerve grafts are possibilities for reconstruct the nerve gaps, and this is how it looks like when we perform nerve grafting in cases with longer defects. This is under the microscope approximation, identification of the fascicles, then approximation of the sural nerve graft to the fascicular, then coaptation of the sural nerve graft to the fascicular group. You can see here the let's say discrepancy between diameter of graft and the fascicular group. Then here you have a microsurgical sutures 1, 2 in an excellent coaptation without tension of suture line with graft to the fascicular group, and then you have 2 grafts on 1 fascicular group in order to complete the suture line due to the discrepancy of the diameter of the graft and the fascicular group, and then you have a complete interfascicular nerve grafting here. Cable grafting is another possibility for reconstructive surgery of polyfascicular nerves with diffuse distribution and combined oligofascicular and group fascicular distribution, with some disadvantages, but generally speaking, they also shows excellent results in about 80% of cases. And this is fibrin glue. You can see here cable graft in the position, and this is modified cable grafting when we use fibrin glue as artificial epineurium to put sutures through the artificial epineurium and real epineurium of the stump in order to maximize and make easier reconstruction of the polyfascicular nerves. And this is how it looks like when the grafts are put into position in reconstructing of the tibial and peroneal component of the sciatic nerve. Nowadays, we have tubes and conduits in our armamentarium. Still is a matter of discussion. Should we use nerve grafting or tubes or conduits? And still, so far, indications for tubes repair are digital nerve injuries and nerve gap between 1 and 3 centimeters. In portfolio of nerve repair solutions, we have nerve connectors, nerve protectors, and also cadaver nerve grafts, decellularized. And nowadays, suture or non-suture anastomosis technique is also in everyday practice question. Some authors, when you have ideal coaptation without tensional suture line, do not recommend microsurgical suturing due to the possible fibrosis on the suture line. They put only fibrin glue, but still, in my opinion, ideal solution is combination of both techniques. When we reconstruct complex elements such as brachial plexus, we have on our disposal nerve transfer procedures. And I will show you now just a short overview of nerve transfer, current standing in a nerve transfer procedures, such as intercostal nerves for reconstructing the musculocutaneous nerve in case with total brachial plexus palsy. Then spinal accessory to the suprascapular nerve via anterior approach. Then viable C5 stump using nerve grafts even longer than 10 centimeters to axillary and musculocutaneous nerve in cases with total brachial plexus palsy. Then thoracodorsal to the musculocutaneous and pectoral medial to the axillary, or vice versa, reconstructive procedures in cases with upper brachial plexus palsy. Then part of the SOMSAC procedures for reconstructing of isolated axillary lesions, such as transfer of the branch of radial for the triceps, lateral head of the triceps muscle to the axillary nerve directly. Then famous and the best procedure so far with the results, Oberlin procedures for reconstructing of the elbow flexion in lesions of the musculocutaneous nerve, possibility for double fascicular nerve transfer, also for reconstruction of the elbow flexion to reinnervate the branch of the biceps and brachioradialis. And then SOMSAC procedure for complete reconstruction of the arm abduction in the reconstruction of the axillary nerve and suprascapular nerve via posterior approach. And this is courtesy of my great friend, Professor Jacques Morcos, some comparative video how mentee and mentor are making a vascular suturing. This is very similar with the microsurgical suturing in peripheral nerve surgery. But the question is the art in the skill and or skill in your art. No master is born perfect, and we have to learn and to train to this. Now we have on our disposal innovations such as robotics, bionic reconstruction, and cloud database possibilities in terms of using artificial intelligence. And in peripheral nerve surgery is a very developing procedure of controlling tiny multi-scale robots for nerve repair. These are examples of endoscopic exploration and repair of brachial plexus with telerobotic manipulation in a cadaver trial using Da Vinci robot. And you can see here that using endoscopic procedure, you have a nice vision and solid space for working, including putting nerve grafting endoscopically. One step beyond the Brazilian group made some advances in using robotic in hand and peripheral nerve surgery in Oberlin procedure with Da Vinci S robot and SOMSAC procedure with Da Vinci S robot. So they report nice outcome for Oberlin procedure in 4 cases and 6 nice outcome in SOMSAC procedures in 6 cases for arm abduction. Most difficult problem in reconstructive surgery of the brachial plexus and peripheral nerves is hand reinnervation, and the most challenging in most difficult cases we have a situation that we cannot do anything, and this hand is non-functional, and even patient itself asked to make an amputation of his hand. Then what to do to compensate this, to make patients some kind of quality of life? This is a development of bionic hand for elective amputation patients. Solutions are still in progress, and this is how it looks like in the most debilitating and devastating lesions. And this is how it looks like, for example, in extremely difficult cases. But artificial intelligence and our actual technologies are developing, and we hope that we will provide some additional help to our patients. There are current limitations of surgical robotics in everyday practice, and despite of theoretical potential in surgical robots, current commercially available robotic systems, they are suboptimal for plastic or reconstructive microsurgery so far. There are limitations of nerve repair in general. We cannot be quite satisfied with the recovery. The patient himself is not, and following perspectives of nerve repair with more efficient surgical techniques. We are working actually now in improving nerve transfer techniques and to side neuronopathy nerve conduits with or without regeneration stimulators or neuroprotectors and other nerve graft alternatives. Future development of brachial plexus surgery is co-dependent with development of whole peripheral nerve surgery, and it is based on application of no-suture techniques and nerve anastomosis or neurotubulus, pharmacological activation and stimulation of nerve regeneration, expansion of knowledge of neurotropism and neurotrophism, concept of cell neurosurgery, and non-neural tubulus. So publishing is very important. We made a lot of publishing in the last 25, 30 years of practice. Actually, there are new books are coming and papers. But publishing the research is very significant, very important. Small series in rare patients are significant. There are not many randomized controlled trials. While consider papers on peripheral nerve surgery due to the, will consider papers on peripheral nerve surgery due to the insufficiency, and will consider small series for treatment variations for peripheral nerve injuries disease in future. And we also need to help our colleagues to publish. Learning curve in peripheral nerve surgery is steep, but it's not impossible. And this is not so difficult from basic through advanced to complex procedures. It can be, let's say, with a nice fellowship program achieved in 2 years, then work, and everyday practice. This is our final goal of the presentation: useful functional recovery of patients who had problems with peripheral nerve injuries to come back in real life, in everyday normal practice. These are all patients who examples of the patients who had injuries on different nerves and come back in a normal life following surgery. So no matter how world would like in 21st century, and this is Earth 5.0 version in the book of Karl-Heinz Land, Provoking the Future. My favorite slide, video teaser, is man or machine? What will happen in the future? Should machine alone make everything, and what the man will perform? And seeking the perfection is mandatory. As you can see, machine is also highly precise. But no matter how the world would like in 21st century, hand of the surgeon will in this field remain irreplaceable factor. And for one who has nothing, a little is a lot. So keep calm and raise awareness and love brachial plexus surgery. Thank you very much for your attention. This is my mentor, Professor Miroslav Samardžić, whose merit in making Belgrade School visible in peripheral nerve surgery is of outstanding importance. And this is my favorite photo that I want to name what surgery done to a man. These are two of us in the last 30 years of our actual work. My family, and I would like to invite you to our online meeting, which is this year in October 22nd, 24, for online activities, and in-person meeting, which was postponed from last year in 2022 in October, European Congress of Neurosurgeons, and I hope to see all of you there. Thank you very much. I'm happy to answer all questions or comments that you are ready to make. Thank you once again for giving me this opportunity, and have a patience to listen to me.
Thank you very much, Professor, for such an enlightening lecture. Any questions from the panelists?
So Lucas, thank you very much for a nice presentation. How are you? You look always very, very great. Thank you very much. Thank you so much. Thank you for invitation for your both big congress. Thanks so much.
Thank you.
Recently, we just one case have. It seems like some problem of the lumbar disease. But actually, we did a surgery of the, I forgot the name of the, just behind the knee, there's some peripheral nerves. So we release, that's the nerve, the patient, the pain of the legs improved. So is it very difficult to make a differentiation such peripheral nerves and also the lumbar disease? So can you tell us? It's very basic question for you, I think.
Yes, thank you very much for this question. This question is of outstanding importance. Yesterday in the afternoon, there was a webinar, WFNS, Committee for Peripheral Nerve Surgery, and CANS and the Egyptian Society under the auspices of WFNS. We discussed issues just what you mentioned. So discogenic or not discogenic sciatica, or discogenic or not discogenic brachialgia. And these are the possibilities. Then you can have a double crash syndromes in terms of having the similar or very alike symptoms, but they are not, for example, from the lumbar spine. They are due to the compression of the peroneal nerve in the lateral knee around the fibular head. So even you can have a motor dysfunction and the lesion of the peroneal nerve due to this compression. But this is the question to recognize all this, to have a careful evaluation of the patient, and then to, of course, nowadays you have a possibility to introduce all kind of diagnostic procedures to clarify this. But this is something that you have to recognize at the moment, and to let's say finish the diagnostic very soon, in order to avoid, let's say, losing the time. And because timing is a very important factor in regenerating of the peripheral nerves, no matter if it is, for example, discogenic problem in a lumbar spine, or non-discogenic problem in a compression of the peroneal nerve around the fibular head in a lateral knee, for example. The same situation is for the brachial plexus. So this is something when we are overlapping, let's say, like spine surgeons and peripheral nerve surgeons.
That's right. Yes. And one question in the future of the peripheral nerve surgery. So do you have some plan with the AI, or can you make some prognosis of how much it's improved or not?
I believe that in future peripheral nerve surgery will also face the fact that artificial intelligence will give extremely big impact to this field, and we have to let's say to adapt to this situation and to involve this new advancement of technology in everyday practice. But this is a question. Biggest question for me is that since this cannot be introduced and involved in all parts of the world at the same time, so some of the countries can introduce this, some of the countries or parts of the world cannot introduce this. But generally, some standard in peripheral nerve surgery is essential and basic. So this is what I mentioned in my presentation. Keep it simple, surgeon.
Thank you. Thanks so much. Excellent talk.
I see another hand.
Yes, it's me.
Yeah.
Yes, me. Dr. Pirzad from Afghanistan. I like to know about, you mentioned about the gunshot wound, peripheral nerve injury due to gunshot wound. And for timing of surgery, and also the result is difficult for gunshot wound and missile injury also. We are faced very difficulties, and ever we operate, but the result is not so good as the other kind of peripheral nerve injury, not gunshot wound.
If I understood correctly, your question is when gunshot wounds should be operated, or gunshot wounds of nerves. Yeah.
Yes. Yes.
Okay. Let's say it like this. Gunshot wounds are usually gunshot wound of the peripheral nerves, or missile injuries of the peripheral nerve are usually not isolated. They are always associated with another injuries. So there are always situations that you have primarily to take care about vascular injuries or bone injuries or something like that. That's one aspect. Another aspect is that in majority of cases, in more than 75-80% of cases, velocity energy is, let's say, shifting the nerve, and you don't have direct impact of the missile to the nerve. So nerve is in continuity, but there is a, let's say, second or third grade of the Sunderland degree of injury of the nerve, and it can recover spontaneously. So that's why in a majority of cases, either you have a situation in the field that you are actually present when some other vascular or bone reconstruction is ongoing, then you see the nerves which are which you can easily reconstruct without tension of the suture line, without defect of nerve tissue. You can do it immediately. Otherwise, you are waiting at least 3 months to see if there will be a spontaneous recovery, especially when you know that the lesion is in continuity. And usually in 75% of cases, there is some kind of spontaneous recovery, which, if it is useful, you are continuing to follow this patient in a monthly evaluation. And if it is not useful, if there is no recovery between 3 and 6 months after the injury, you operate this patient.
Thank you.
Another hand is raised, I can see here, but I don't know if it is a question.
Yeah, Professor Lucas, I'm a young neurosurgeon from Afghanistan.
Yes.
Dr. Reshad, I have 2 questions, and one of my questions goes to you. And the question is, you have spent decades of your life in neurosurgery. What will be your only constructive piece of advice for young neurosurgeons? Because it's our baby steps in neurosurgery. And I will be helpful, and I will be happy if you could give us some advices. Thank you very much.
Can you repeat once more your question, because there was sound mixing. I missed some part of your question. Please repeat it once again.
My question was that I'm a young neurosurgeon from Afghanistan.
Yes.
And there are lots of other young neurosurgeons who are spending their baby steps in neurosurgery.
Yeah.
So if you could give us a constructive advice in this field of neurosurgery, it will be very helpful for us. What will be your message for us who are taking their first steps in neurosurgery?
You mean you are asking me advise you to go for peripheral surgery, or to advise you how to approach to the neurosurgery residency in general?
Yeah, in general, yes, that's it.
Well, I suppose that this, as far as I know, situation in Afghanistan is not so easy, and I mean, it's not so easy in another part of the world also, but you have to go for your vision. You understand me? If you have a vision to become a neurosurgeon, then you have to fight for it. So you can fight it within your local environment. You can try to find another environment. You can write, for example, to Yoko Kato to myself, to another colleagues all over the world for some support in terms of fellowship or whatever. There are a lot of possibilities for doing it, but most important is that you have in your head a clear vision. What is your goal? And if you are not have a possibility to have a lot of practice, some reasons, I don't know which reasons might be possible, but generally speaking, you have to find a way where you can go for the practice, because in my opinion, theoretical and online education is not enough for a neurosurgeon. You understand me? You have to have a patient contact with the patients, and you have a contact with the operative theater. You have to go to for the surgical procedures to learn for that, not only via educational platforms, via, I don't know, web or theoretical, but also you have to go to have a possibility to see patients and to go for a practice. If you have this, you have to just have a clear vision and to go for this directly. And if you ask me, should I recommend you to do peripheral neurosurgery, I will simply say yes. But don't remember, you have to have in your mind that you have to first to finish general neurosurgery residency program. And then after that, you go for specialization for peripheral neurosurgery. So you have to be able to operate vast majority of the conditions in general neurosurgery, trauma, oncology, vascular, spine, generally. But you have to be expert in one field. That's later on, after general residency program, which is 6 years in Europe. And generally speaking, if you have some centers in Afghanistan for this, you have to have some educational program on the national level, which can collect all of young neurosurgeons in Afghanistan and then involve you in education on the national level. And this is why WFNS is existing to support all these activities. And of course, we personally, individually, will support you in any manner. And if you want to come in Belgrade to see something of neurosurgery, I can help you in terms of making easier some circumstances of your staying in Belgrade for, I don't know, 6 months or 1 year. I don't know how much you are ready to come. This is how it works generally.
Thank you very much. Thank you.
All over the world.
Yeah, thank you very much. Thank you.
Thank you, Professor Lucas. Thank you. Thank you very much.
I was in Pakistan in 2019, and there was my short staying. Otherwise, I will come in Afghanistan to see some of your country. But generally speaking, I was a very short time, 3 days only, so I was not able to come. But next time, I really would like to come to see you.
Yeah. Okay. Thank you very much. You are
Thank
welcome.
you. Thank you very much.
Welcome.
We will be happy.
Thank you. Thank you, Professor Lucas. Thank you.
Thank you very much, Professor.
Once again, just want to tell you that very soon, Professor Yoko Kato, she knows that she is involved in all activities of WFNS, but we are preparing task force initiative relating to the peripheral neurosurgery through the WFNS Committee of Peripheral Neurosurgery, and you will receive all this information for different possibility of learning peripheral neurosurgery in both ways, either to come in your country, either you to come in some training centers or all over the world. But this is regarding peripheral neurosurgery.
Okay, thank you very much. Thank you. It's good news. Thank you very much.
And once again, I would like to thank to Professor Yoko Kato for her outstanding support and friendship, especially to me and to Serbian Neurosurgical Society. She's always supporting us as well to the Japanese colleagues, Japanese neurosurgeons, Japanese Neurosurgical Society. They are always supporting all our activities, and this means a lot of us, and this really improves the quality of neurosurgical service in Serbia. We are still working together on some additional projects, but most important is that our friendship and support is lasting and improving. So thank you, Professor Kato.
Thank you, Lucas. Thank you for a nice guidance for how you can support the YNS, especially the developing countries. Thank you. Besides your excellent talk.
Thank you, Professor Kato, Professor Lucas, Professor Sachin, and all of colleagues that they are focusing on Afghanistan and Myanmar for helping developing countries. Thank you very much. Arigato gozaimasu.
I have another Zoom meeting, which means that I would like to excuse. I don't want, but I have to excuse myself. I have to go to another Zoom meeting. So if you understand me, please, thank you very much for this. But I will leave this meeting now and have to go to another meeting. Okay.
Okay.
Thank you. Thank you very much, Professor.
Thank you so much. Thank you.
Thank you. Bye.
Bye.
Bye. Bye.
So back to our conversation. I would like to apologize that Professor Ivan from Canada is not able to join. I tried contacting him, but I think there's some misunderstanding about the dates and he's not able to join us. So we'll go ahead with the case presentation from Sri Lanka, Dr. Hemanta. Dr. E, can you share your screen and introduce Dr. Hemanta, please?
Okay, sure. Well, now I would like to introduce Dr. Hemanta Gonatilaka from the Sri Lanka, and he got his MBBS and master degree of surgery at University of Colombo in 2013 and 2019, and currently he is working as a senior registrar in neurosurgery at National Hospital of Sri Lanka. So, Dr. Hemanta, this is for your blog. Thank you.
Thank you very much for that kind introduction. And I'm Dr. Hemanta Gunatilaka, Senior Registrar in Neurosurgery from Sri Lanka. And first of all, I would like to thank the organizing committee of ACNS YNS Association for giving me this opportunity to present in front of giants in neurosurgery. From this short talk, I would like to give a small introduction and basic overview regarding how neurosurgery is in Sri Lanka, as well by going through a person who was having thalamic lesion. First of all, I would like to introduce my hospital. This is the National Hospital of Sri Lanka. And so neurosurgery department is in the fourth floor. So this is it from another angle. This is my consultant, Dr. Deepa Lattanayaka, who is consultant neurosurgeon of National Hospital of Sri Lanka. I'm grateful for him for guiding me these days to become a successful neurosurgeon. So let's move on to my patient. This is a 54-year-old retired army officer who is a married father of 3 children and breadwinner of the family. He presented to us with progressive left side face, arm, leg numbness and weakness over the last 2 months duration. And on presentation, he was having difficulty in walking as well. And he complained of recent onset vertigo for last 2 weeks duration. There was no seizures or vomiting. And his past medical and surgical history also were unremarkable. When we got to the examination, his general examination was normal. His GCS was 15 out of 15, the hospital stay, and his higher functions was also normal. And pupils were 2 millimeters reactive. And when it comes to cranial nerve examination, there was left-sided facial sensory impairment, and all the other cranial nerve examination was unremarkable. When it comes to upper limb and lower limb examination, he was having left-sided upper limb and lower limb motor weakness of MRC grade 4 out of 5. And the sensations also impaired of the left side of the body. And there was no cerebellar signs of this patient. So this is a pre-op video of this patient. So there's a drifting of the left side. When it comes to the gait assessment, there was an unsteady gait. He was falling onto his left side. I don't know whether videos are clear for you all. Is it clear? Yeah, so we investigated this patient with MRI scan of the brain. So you can see the FLAIR images shows us the hyperintense lesion of the right side thalamic region. And when it comes to the contrast enhancement of gadolinium, the lesion is not enhanced. So this lesion is compatible with the clinical signs of our patient. These are the coronal cuts of the MRI, and these are the sagittal cuts. So we plan to go ahead with the excision of this right side thalamic space occupying lesion, and we did preoperative anesthesia assessment, and it was unremarkable. So we planned for surgery, and we did the surgical intervention. So during the operation theater, we positioned the patient on the Mayfield, and due to the financial crisis and logistic reasons, we don't have MRI navigation in our theater. So we had to do the surgery with the available MRI images. But to facilitate our surgery, we used intraoperative fluorescence guidance for the resection of this tumor. So after cleaning and draping, we perform the craniotomy over the parietal region, and dura was opened. And this is a short video of our surgery. I think you all can see that. So with the fluorescence, we could identify the changes that was there in the thalamic region. with the assistance of the Cavitron ultrasonic aspirator, we resected the tumor as much as possible. Preserving almost all the vascular structures around the lesion. And as we didn't have this MRI guidance, usually normally we are sending intraoperative frozen sections. So frozen section revealed low-grade glioma for this patient. And after the excision, what we are doing is we are sending the margins for histological assessment as well. So the margins showed a frozen section of the margins also negative for this patient. So this is at the end of the surgery after achieving the hemostasis. So when it comes to intraoperative investigations, frozen section showed a low-grade glioma. And this video is the post-operative video of the patient. We have preserved the functional status of the patient, and he could walk, and the sensory loss was still there after the post-operative period as well. Unfortunately, due to the logistic reasons, we couldn't perform a post-operative MRI scan of this patient, and we are planning to perform the post-operative scan very soon. And with that, if there's any residual tumor, we are planning to manage that. And for further management of this patient, we are getting the oncologist opinion for further treatment. So that's the end of my short talk. Thank you very much.
Thank you very much, Dr. Hemanta. I must appreciate that is one of the very wonderful surgery for thalamic lesion especially. And you're doing almost everything which is that part of the excellence. You've got the best microscope, you're using fluorescence, you're using intra-frozen and margin negative biopsies. That is a state-of-art surgery, I must say. But are you able to perform this kind of surgery throughout the Sri Lanka, or it is only, concentrated high-end surgeries you're able to do only in certain part of the Sri Lanka only?
Actually, in Sri Lanka, we have 9 provinces. Almost in all 9 provinces, we have general hospitals where neurosurgeons are there. But only the navigation facility is available in only National Hospital. We have only 2 theaters. We have navigation, MRI navigation is available. And out of Colombo also only in 2 or 3 stations the MRI navigation is available. So these fluorescence and all also we are using only in few stations, and because the microscopes are also not very good in some stations, but in national hospitals and few other stations we have very good microscopes. So this is how we are doing neurosurgery in Sri Lanka. But with that, we are achieving a lot of, we are managing almost all the patients with these facilities.
Thank you very much. Dr. Liu, you want to say something?
Yeah, thank you, Sachin. Thank you, Dr. Hemanta, for a very nice presentation. And sometimes we need to work when we are lack of resources, the way that you have done it. The only issue is now at the moment, I think the fluorescents are not working so well, especially with low-grade glioma. That's why you may have some difficulty to look at it probably works better with high-grade glioma. But anyway, I congratulate for the effort that you have shown to us, your courage to present in front of the big professor, Professor Kato. That is a very big success for you. And hopefully, I think I visited your country once, and I think the government are doing quite well. I think you also have formed part of the, I think, membership in the World Federation, if I'm not mistaken. I attended your in the society meeting. I think it's very cultural and very nice. Hopefully, you all will be having a big success. And I know that you have also a trained neurosurgeon from UK who visiting you on annual basis. And I think that is a very good step forward. And I would encourage from any one of you at the residence level or a young neurosurgeon to join part of the ACNS training program. And we do have a lot of opportunity. Hopefully after the pandemic, we see you all to come to this part of the world, even to not only to Japan, probably India, and many parts of Asia that we can learn together. Thank you.
Thank you very much, sir, for that kind words, kind encouraging words, actually. Thank you very much.
So Dr. Sachin, maybe I think this is a glioma related some problem. Maybe the Dr. Chen from Shanghai, she can give some comment to him, I think.
Sure. Dr. Chen?
Yes, I'm here. Very nice presentation. And this is, I think this is a very dilemma and a tough case. The after operation treatment decision decided by how much tumor volume you resect. So usually in our country after operation in 72 hours, we will do the MI scan again and make a decision how many volume residual tumor. And do you have a molecular genetic panel detection in Sri Lanka? Usually, yeah, no. In our pathology department, we can do IDH, MGMT, and most time, we have to send the tumor tissue into the genetic company. They will do the molecular panel. It's a bigger panel or whole exome genetic. Okay, so if you have information of a MI scan after operation, you can see usually low grade glioma has grade 1 or grade 2. I think if the residual tumor size is very small and grade 1, maybe you can just observation, do the observation. But if the grade 2, maybe, and do we have a MGMT detector? If MGMT positive, we perform temozolomide chemotherapy. And about regarding radiotherapy, maybe you can delay to do the radiotherapy, except the tumor is grade 3 or grade 4. Now WHO pathology molecular tumor border is changing. I will send snow training. This is new training about the C impact now. It's update about molecular pathology. So sometime in our case, in the frozen diagnosis, it's low grade glioma, but after molecular diagnosis, the grade is updating. So in my suggestion, maybe you can ask pathology again. Maybe they can do IHC. You use some to do pathology diagnosis is very important. Grade 2 or grade 1 or grade 3. There are total different after operation treatment is totally different. If the tumor is grade 3, in our case, we met the ceramide tumor is grade 3. Sometimes it's grade 4. We do the radiation therapy after this after operation within 4 weeks. Yeah. So this is a very dilemma case. Let's follow up. Yeah, that's a follow up. We want to see the MI scan. And I will send the snow impact now updating tumor board information in our ACNS group. We can learn the updating knowledge. Okay. Sometime in China we have some new clinical trial. In glioma, some low grade glioma has BRAF mutant. BRAF class, so we can suggest a patient enrollment to the new targeted drug trial, because this is very tough location in brain, ceramide. Okay.
Thank you very much for that. We will
Okay,
follow up
thank
with the pathologist, and then we'll do whatever possible for this patient. Thank you very much.
Okay, we can change our email and we can keep a follow for this case.
Sure.
Thank you.
Thank you, Dr. Chen. Dr. Hemanta, I'll send you her mail address. She's an excellent glioma surgeon. So you can you can update her about the histopathology, and definitely she'll guide you.
I will send the histopathology, and I will contact the histopathology for the immunohistochemistry and all the investigations, and let you know. Sure.
Thank you. Thank you. Anybody? Professor Takio Goto, maybe your expert comments on thalamic glioma, about the surgery Dr. Hemanta has done.
Okay. At first, I feel very impressed. The nice, sophisticated surgery, Dr. Hemanta. I think the surgical technique is not so different in Japan. He directly observes the border between tumor and neural structure, and he nicely used a cursor and also use fibula. So I think the surgical strategy and technique completely catch up the already developed country. So I think I'm very impressed the surgical technique in Sri Lanka. It's just comment.
Thank you very much.
Thank you, Professor. Anybody? Dr. Javid is there. Dr. Javid, do you want to say something?
Thank you, Sushen, and thank you, Prof. Kato, Dr. Liu. Thank you very much for invitations. I think this is regarding Afghanistan's, Myanmar, and Sri Lanka webinars on education. I think as a panel, thank you to inviting me. I just want to introduce for those who are not familiar with me, because I know Professor Kato for the past 11 years and all the conference and everything. I'm one of the diaspora of Afghan origins, resettled in Malaysia. And we do have a lot of expatriated Afghans, like they are in Harvard Medical Schools, Dr. Ali's in Germany, Netherlands, and Pakistan. Actually, we do have good number of neurosurgeons we resettle outside. I'm not the presentation of Amanta from Sri Lanka was excellent. A little bit I divert the conversation. I'll just comment a little bit about Afghanistan. I just want to say a few words and come back. I'm visiting Afghanistan as a visiting surgeon on yearly basis, going there and visiting, and the situation is totally different there. I just want to highlight a few things if the panel of ACNS basically can hear. And thank you very much, Prof. Kato and ACNS to awarded for scholarship for Afghan. I think absolutely it was a need of time. that these people will come. And thank you for support. But I think Afghanistan, as one of the young surgeons asked from Professor Lucas, like what's the steps for Afghan neurosurgeons? We do have a lot of challenges apart from war and all other things in Afghanistan. The challenge is basically the education in Afghanistan is in local language. It's in Pashtun, Dari. And the barrier of this is if someone wants to come into they have to speak English. I mean, this is one of those things. And I think if the ACNS can do some sort of, it's my suggestion to give to Afghanistan or Sri Lanka or Myanmar, I think, because all of us in the same ship, as a mentorships kind of programs. The majority is not so much big. If each consultant overseas can take 2 or 3 students as a mentee in mentorships, I think it will be really it will have great impact and guide them. One. The second thing is Afghanistan is in terms of research. I think there is devastating things. I think there's really the research is not existing there, and there's the pools of data there. While if you're searching for Afghanistan data, all being used by American soldiers and from other people they have done, but for Afghan, I think if the ACNS can, this is my suggestion to help them out. Basically on research basis, because we do have head trauma. It's huge if they can basically help them out in research. That will be great. So we are here and thank you very much ACNS, and thank you all basically to put all this together, because as Professor Kato said, Afghanistan resemble an Olympic. Yeah, of course, I think we have been in Olympic. In Afghanistan, it start with A, and we are the first coming to Olympic. So basically, and Afghan, I think at this point of time, we need a little bit of support, and the resources is there. And session, I mean, I'm coming back to your question you asked from Prof. Goto about resources. I think resources with limited resources, I think in my opinion, I think the basic, we have to follow the basic. The basic is basically you have to have excellent on your knowledge and neuroanatomy and all other things. Once you're getting there, I think the resources will come back from somewhere and you can catch up with that one. So with that one, thank you Sessions for inviting, and excellent presentation by Dr. Hemanta. It was really, I'm very glad to see that, that's that level of surgery. Thank you very much.
Thank you very much, Dr. Javed. So we have Dr. Reddy Ramani also with us. He's basically from Albania and now he's in New York. Dr. Reddy, you want to come in? You want to say anything?
Hi, everyone. I just wanted to say thank you for involving me in this. As you mentioned, Professor, I am originally from Albania, but I emigrated to the United States, and I've made an opportunity here in training in neurosurgery. So I'm looking to get involved in neurosurgery on a more worldwide basis, and being part of educational opportunities like this. So I look forward to future meetings like this as well. Thank you all for the presentations that you guys have given today. Very educational.
Thank you. Thank you very much, Lindy. We also have Dr. Tony and Dr. Natalia from Russia and Bulgaria. Dr. Tony, Dr. Natalia. If anybody from the panelists has any question? Yes, Dr. Chen, Dr. Pirzad, you want to say something?
Yes, thank you very much. Thank you for Dr. Javed for nice comments. And I agree with Dr. Javed. And as I present in the first day, that's we are facing with war in Afghanistan and unsecure situation in all the times, and also due to economic and financial problems, and also to shipping the equipment and material to Afghanistan. It's also costed for this reason, and also the other thing is the training outside Afghanistan is also difficult for Afghans with low resources, and the government not supports such training. And we agree with Dr. Javed, international and also ACNS support for training, for equipment. As I also thanks for Professor Kato and Professor Sachin and all colleagues that they support for Afghan residents for training, and this the biggest steps. And also Professor Kato promised that they will give 2 drills for craniotomy, and I think this good starts for Afghanistan and good news. And thank you for Professor Lucas and Professor Kato and all colleagues that they interested about Afghanistan and like to improve neurosurgery in Afghanistan. And every comments, every things that you donate for Afghanistan, we don't forget it. Thank you very much.
Thank you. Thank you very much. Dr. Chen, you want to say something?
Yes, I think of a question and about the celamide tumor. Dr. Hemasa, do you have an operation electrical monitoring when you do the operation? And how do you know you push the surgery to the limitation? Yeah.
Dr. Hemanta, do you have intraoperative neuro monitoring system?
Yeah. Monitor.
I think there is some network problem with Dr. Hemanta. He got disconnected. Dr. Hemanta, yeah, you're there. Do you have intraoperative monitoring system in your hospital?
Intraoperative, what we have is intraoperative the navigation MRI systems only in some centers. Apart from that, we don't have other intraoperative monitoring system. Like we are using this fluorescein dye sometimes only. That's also not readily available throughout the country. So we don't have any intraoperative monitoring systems at the moment.
Okay, thank you very much. Any other comments or any question from any panelists before we close?
Just one question I will ask from Prof. Gatto. I haven't got a chance to ask him. Regarding the case Prof. Gatto, you showed, it was excellent case you showed. And, regarding the craniopharyngioma that you have shown before, the opening was quite big enough, and you just repaired that area. So what's your experience regarding the CSF leak and infection? What's your rate of infection of CSF leak? Do you encounter any problem with all those cases you have shown, Prof. Gatto?
Thank you for question. In case of the endoscopic endonasal approach, prevention of the CSF leakage and infection is very important. So usually the dural defect is large. I recommend to you to harvest the large nasal flap. And then I recommend the suture of the dura mater. At first, I insert the fat tissue to subdural layer and put some suture to fix the fat. And then, after confirmation the CSF completely sealed, I cover the mucosal flap over it. So multiple prevention is very important to prevent the CSF leakage. In addition, if we perform the surgery to the subdural area, we use the antibiotics of the third generation for 1 week to prevent the meningitis. Even the dural seal is perfect. In case of the subdural surgery, meningitis can cause the increase of the high pressure. It leads to the delayed CSF leakage. So the if we use extended endonasal approach, I recommend the antibiotics for 1 week. It's a small tip to prevent the infection and CSF leakage.
Thank you, Prof. Thank you very much. Thanks.
Regarding the CSF leaking in China, we have experience when I watch the operations, they do U-type mucosa staging. And you can just like open a book. When you want to suture the mucosa, it's easy to make a block to the CSF leaking. Do you have such experience?
Yes. When you perform the transcribal approach, if you access the lower clivus, U-shaped flap is very effective to seal the drug defect because the pedicle is large. So it's very effective to strongly contact to the clivus.
Yeah.
Yes.
Okay,
So
thank you.
in some case, I use this technique.
Awesome case. Okay, thank you.
Professor Gato, another question for you. So when you will do a subdural surgery, do you use lumbar drain as well?
No. If you use a large mucosal flap, usually, of course, in my initial career, I'm afraid of CSF leakage, so I use lumbar drainage. But in my opinion, no need to perform the lumbar drainage.
Any other question or any comment from any of the panelists? Dr. Tony, Dr. Natalia? Okay, if there are no questions or no comments, then we will wind up the discussion. A last closing remark from Professor Yoko Kato, and then after that we'll wind up the discussion.
Okay, thank you very much it's a wonderful meeting. So just because Professor Goto's great lecture is very informative, and also the young guy from Myanmar was nice, I think. So everybody said that your technique and also the instrument was almost the same, which we use now. I think maybe you should learn a little bit more about glioma itself. So maybe you can discuss with Dr. Chen, exchange the email, and also the surgical approach to the thalamic. I think another issue, I think. But anyway, the conversation here, great, the lecture. And as ACNS, I think we can exchange some such kind of the case consultation in the future, anytime. The immediate case, the emergency case, maybe you can make a phone call anytime. It's okay, I think. And also, Mr. Ono, he demonstrated very good his company's the product. I think maybe some videos of the he used already in several the meeting, so we can get some nice video, and Dr. Liu or Dr. Sachin make some put up our website, and also in autumn maybe Dr. Liu will make an announcement. Some in November we have another the meeting, so we can invite. We focus on the young neurosurgeon, not the big top runner, but I think we want to focus on the young neurosurgeon and also the who is going to how to say the expert in near future. I think. Such Dr. Liu, can you make an announcement about that?
Thank you, Professor Kato. We will have our next 2 days seminar on 20th and 21st November. Again, our focus will be mainly 2 things. One is on the workshop. We will be get our expert to tell us more on the anatomy and neuroanatomy and also surgical techniques. And again, we also emphasize on young neurosurgeon presentation. And I think the last session that we have in summer seminar, we have about 24 participants, and hopefully we can have more this time. And we allocate more time for the young neurosurgeon to show what they can do. Thank you, Professor.
Yes, thank you very much for all your participants. This wonderful the YNS community meeting. Thank you, Sachin, for your great efforts to make such great organization and collect so many YNS. Unfortunately, we cannot exchange an opinion among us, but I think it's very wonderful meeting. Thank you so much. And also Albania Guy. So you are one of the best recommendation by Arion, who is living in Toronto. So we are very proud of you. Thank you very much for coming today.
Thank you for having me.
Okay.
Thank you. Thank you everyone for joining and making the discussion more interactive. Thank you very much. Thank you very much, Professor Takeo Goto, Professor Pirzad, Dr. Javed. Thank you very much.
Thank you.
And all the ACNS YNS members. Thank you very much. Goodbye.
Thank you very much. Maybe bye, Jen. Thank you. Very good comment.
Thank
Now
you.
you are master of the glioma. Now.
Yes.
Okay, thank you. I'm learning and I'm working work hard for this. Thank you.
Yes.
Okay.
Maybe
bye.
Dr. Pirzad, yes. Maybe
Yes.
Pirzad, maybe Dr. Goto will support how you can extend the endoscopic procedure in your country, I think.
Okay.
Goto sensei, お願いします.
Okay, I will contact through email with Professor Goto and through Dr. Sachin will share the email addresses also. And also we can join with Dr. Javed Khan also. That's he knows about well about Afghanistan. Okay, Dr. Javed.
You okay?
Okay, thank you.
Thank you.
Thank you. You want to show us some video? Promotion video?
Okay. Yes. I'll show.
Last 2 minutes.
Just last 2 minutes, yes. Okay. Yes. Just 1 minute. Yes, I got it. Yep. Share sound. Yes. So thank you very much. And next webinar will be on 8th August 2021, a session dedicated exclusively for vascular neurosurgery. We'll be having Professor Amir Qureshi, who will be talking about development of the carotid and vertebral basilar system, the embryology of vertebral basilar system and carotid arteries. And then we'll be having Professor Vladimir Benes, who doesn't need any introduction, a giant of vascular neurosurgery, who will be talking about brain AVMs, and Professor Kojiro Wada will be talking about carotid endarterectomy, whether carotid stenting or carotid endarterectomy. Thank you very much.
Thank you. Okay, see you next time.
See you next time. Thank you.
おやすみ。再见。再见。
Bye bye. Sayonara.
Bye. Bye.
Sayonara.
おやすみ。はい。
Yeah, thank you. Bye.
Thank you. Thank you, Prof. Kato.
Dr. Hemanta, thank you, Dr. Hemanta. That
Thank
was
you, Dr. Sachin. Thank you for giving the opportunity.
one wonderful surgery you showed. It's not a surgery done at each and every place. So you are at part to the developed countries and the art of excellence.
Thank you very much, sir.
Good. Thank you. Maybe next time, when the next webinar, you can tell us about what was the histopathology and what was done.
Yes,
Just
sure.
1 minute.
Sure.
Thank you. Thank you very much. Thank you very much for the support from the Intas Pharmaceutical, Mr. Vishal and Prashant. Thank you very much. You can close the meeting now. Thank you very much, Dr. Pirzad.
Okay. Next time,
Yes.
Dr. Hamid will present his case, inshallah.
Sure. Inshallah. Thank you very much. Yes.